People to the quiet. They're the ones that are here. So what I wanted to talk to you today is it's about heart failure and really important topic. I see our new employees being quite overwhelmed with cardiology, who just graduated from here, and I realize that this stuff is really hard, and you can't expect too much of yourself. You can't expect that you get one lecture on heart failure and all of a sudden you're expert and you know how to treat heart failure. That's not the way it works. It takes years to get comfortable with cardiology. So a lot of the stuff that I put on these notes that I gave you are there's cancer questions. I mean, there's a question about diabetes on here. There's a particular diabetes treatment that you don't use with people that have heart failure. I've never seen that on the family. So this stuff, I don't want you to just pass the test, but a lot of this stuff is really practical. So what I did instead of making a PowerPoint, but I had a PowerPoint. I looked at it and I thought, well, it's really boring. And I didn't even remember all this stuff. So what I did is I did what we do in clinical practice. Is we practice by guidelines. That's what you might hear people say gold standards, that kind of thing. And they're based on the latest research. And the latest heart failure release was in 2013. And the organizations that release information, and it's published in JACC. JACC is the Journal of the American College of Cardiology. Very prestigious, like New England Journal of Medicine, prestigious. But JACC always publishes these guideline statements. So this was made up by the American College of Cardiology Foundation and the American Heart Association. American Heart Association is also another prestigious organization, but it has a different purpose than American College of Cardiology. American College of Cardiology is directed toward practitioners. The American Heart Association has programs for lay people and the public. For example, advanced cardiac life support and basic life support programs, smoking cessation. All kinds of outreach things are published by the American Heart Association. Things that you guys are aware of that, right? I've heard of American Heart. So when these kind of organizations come together, it creates a very readable, evidence-based document. The document is like almost 100 pages long. And I posted it for you, but it's in black on the outline because the actual document, I'm not going to take some obscure fact, page 67 of the document and test you on it. But if you so desire, I think that you should have the reference value to make up the talk that I have for you today that I'm going to use in the testing. So this is where it came from, and the fact it's reference to the electronic page that I got it from. And so I gleaned all this stuff that I thought that I use all the time for heart failure, and it's evidence-backed by years and years of research. Now, one thing that I'm not going to go over with you, but the docs will talk about is level of evidence A, B, and C, and D, and that kind of thing. And so the stuff that I do today is from the highest level of evidence that supports it. The docs actually know whether or not some things that we do because they're higher level of evidence, and some we do even though they're not real high level of evidence because they make us comfortable. And we have anecdotal evidence of personal experience. And then a good example of that would be using coenzyme Q10 and vitamin supplements. As far as that really help heart failure? But now the evidence doesn't say that it does, but we still do it. Things like getting annual mammogram or PSAs and things like that, the evidence may not show that really does change outcomes that much, but it's what people feel comfortable with. Some of it we can or can't do because Medicare guidelines won't pay for things that are the highest evidence standard. So we have to start talking about heart failure because it's a very important topic that's you're going to see on your test and in your practice. And we'll go over a couple of statistics that kind of wow you with. This probably is worse than cancer. And it's a very unpleasant way to die of heart failure. So whatever we can do to make our patients feel better. So what I recommend you guys do is, print yourself out one of these. It's both sides. It's not too bad. Rather than a PowerPoint. So yeah, everything on that handout, that printout is testable stuff. Okay. You know what I'm talking about. Then I need two more handouts for you. Approach to the patient with light flow. So then you go to color picture. I have some nice pictures. I'm going to talk to you about light flow in particular because people think that light flow means they're in heart failure. It doesn't. I bet that some of us can come up with some light flowing in ourselves, and I'll show you how to test for that and break that. It doesn't mean heart failure. The other thing that the students have trouble with is regular assessment, regular vein assessment. So I made you up one I really like, and I'll talk about that. So that's two physical signs for heart failure that are worthy of going over into more detail. So we'll talk about that in a few minutes. No particular order. And then I published 9 cardiovascular cases, and instead of torturing you and go into groups and try to figure out the answers and come back and talk about it, that's just a lot of time to do that. I just go and give an answer. So I think, and what these are is, some of these are real patients of mine, and I have used these for test questions in the past, so these are good examples of the case studies kind of questions you're going to get on your CV2 exam on heart failure. The heart failure really lends itself well to asking you to figure out the answer. You got to figure out the diagnosis and the treatment. So instead of a test question, which is the following of these is an ACE inhibitor, and one of them an ACE and the rest are ARMs, something like that. That's what the kind of question you're going to get is. That's just the way past that. It's time to, we'll start to have a couple questions of case studies. The first test was easy into cardiology. And you did real well, and there weren't much in the way of case studies. But so study these for ideas of what kind of questions are there in heart failure. So they're really similar in difficulty to these. So what I was going to do originally was I was going to have half of you go over and quiz each other, like 3 2 days, and then talk to your partner and see if you could come up with the answer. So you're not going to have the same question verbatim when you got them. It's real similar. Okay? And in the lower there's even ones on lipids. And that's because you should take care of lipids if you're taking a heart failure. You got to try and fix as much as you can. So then now that we have a smaller group, we can do this very well. Okay. And so someone asks you if you don't understand why this, and if you say, oh, this contradicts something that we gave us as far as these notes, that you do this. That's because the art of medicine is you're going to get 2 different answers as how you treat somebody. So you might see something that just seems out of order to this, and there may be a reason for that if there's some detail that's not in there, but there'll always be 2 good answers on a test question, at least out of the 4, 2 are going to be plausible. You got to do some test questions. So I'll make it clear as to what's a better choice, because there's a lot of contraindications on here with heart failure and these notes. So that once you may see something that's a contraindication put in there because they want you to know first do no harm, first do that, right? That's our providers. So you're going to get a lot of the do harm precepts put in it and distractions. So I look for that. Okay, not just like the rule. I'm trying to get away from using the word not and accept, negative questions, double negatives, that kind of thing. Two things in an answer. So we're getting better. Okay, so if you will, I couldn't bring it up there, but if you just bring it up on your computer, if you bring up the guidelines for national heart failure, what we're talking about. No. It's the big one, it's 7 pages. No, not the big one. No. That's just the records for this company. When we do the case numbers, if you want further clarification, you don't understand what I meant, when you have time on your hands, you can read it. It won't hurt you, but I don't mean for it to confuse you or to make you think you have to memorize all those different stuff. So the stuff that I picked out, I feel is important. So So you are responsible if you want to take it. This is your, same as your PowerPoint, this document, and these other two documents. This is also testable material. Okay. That's the JD and the writing medium. We're going to go over in a moment. Okay? All right. So I'm just going to talk about this a little bit. Because you all can read, and I know you have a lot in your mind, and we're about to test and stuff coming up. But just give me a chance to go over, bring up a few points. I'm not going to read it verbatim. And if you have questions, when you stop me, please stop me and ask. Okay? I'm going to see. So the first paragraph is just about guidelines, which I mentioned, why that's important. And of course, they recommend that we involve our patients. And if you don't explain what's going on to patients, like you don't want to exhaust, I mean, I've seen sometimes with exhausting my patients. So you don't want to give them more information than they can tolerate. And heart failure is can be hard to understand. Some of these diseases. I had a problem yesterday in clinic. I had a lady who had DVT and she had a ventricle, she had a hyperdynamic heart, and her ventricle squeezed obliterated the cavity. So I had to give her fluid so that she had enough volume that she would obliterate the cavity, but at the same time she had DVT, and we were giving her diuretics because we had life swelling. Diuretics are not that helpful for life swelling after that deficiency. So this is treatment contradictory, but trying to explain to her why we're doing this, why we're doing certain anticoagulations, why we're doing certain kind of anticoagulations before. And you have to really simplify it. So you can't simplify stuff for patients if you don't understand it yourself. You got to give them the right thing. Yeah, it's hard to do. It's really anxious and it's really frequently. But I got through it, but it can be tough. So anyway, that's one of the clinical behaviors is involve your patients. So when your patients get really good with managing their disease, they even adjust their own diuretics. They know when they should take an exhalation cell to get rid of the fluid, when it's okay to. It's making an appointment with you and asking information, and by then they're ready to go to the hospital, so you can avert it. And that's one thing I'm really proud of that I do in clinic is I avert a lot of hospitalizations. So I treat them as an outpatient. And that's a good question for you. Everybody that I diagnose with heart failure, they need to go to the hospital. That takes years to really have a good handle on. I mean, that's when I was brand new PA and I was working with a doctor, and they'd ask my opinion to do a visit for the immunity. And they don't even do that anymore, it's dangerous. But if I have to decide, how bad is this heart failure? Should I tell the doc I think they ought to go to the hospital, or should I tell them I think they should go home? So that was kind of scary. They could look on wrong and they could go home and die. So it takes a while to be real comfortable with heart failure happening. So anyway, what is heart failure? They don't want to call it congestive heart failure anymore because it's not always congestive. The treatment for heart failure is not just water pills. It's not like get rid of the water and you're fine. That's not it, and that's what we used to think because that's about all we have. Water pills is good out. Now we have a lot of great treatments for the disease treatments. It's when the needs of the body are not met by the pumping of the heart. So there's a more detailed thing. What the main thing is the heart can't meet the needs of the body. The two main symptoms are shortness of breath or dyspnea and fatigue, because you can't meet the needs of the body, you're not meeting the needs of the muscles. And then your stomach, you have stomach upset, you don't circulate with your stomach, your organs don't perfuse, and you get organ failure, so your kidneys and your liver don't work properly, and then you get fatigue from this whole body is ill, you kind of get ill from the heart failure. And you could have like a dry heart failure, where you weren't overloaded with fluid at all. The main thing is just the fatigue. And this all happens when elevated intracardiac pressure. Remember we talked about that before? You got too high pressure inside the heart, it's a function of the work process. The pressure's too high inside the heart, then the fluid is moved into the tissue. And that's where you get the dyspnea from. And you get the fatigue from the hypoperfusion. So you may or may not have fluid retention. And we'll just call heart failure, HF on this document. Now, we have talked about cardiomyopathy and myocarditis. It's not synonymous with cardiomyopathy. It's when the ejection fraction is even normal. You can't even define it by ejection fraction. You can't even say, oh no, the ejection fraction is low, so they must have heart failure. I have people with ejection fractions of 25% that have full time jobs. I have people that walk around with blood pressure of 80 over 60, and they still go dancing and do all kinds of stuff. People vary tremendously as to what they can tolerate with heart failure. So you cannot put it in little categories. This is what heart failure is. It's very complex. Okay, you can see on the second page there's the example of the ejection fraction idea. And this is what the CMS uses. They talk about systolic heart failure when you go with differentiate that. So systolic heart failure is probably the easiest one to understand. Systolic heart failure, they abbreviate that in the document. Heart failure, the R means reduced ejection fraction, small r reduced ejection fraction. And that's less than or equal to 40%. And that worked out pretty good because people understood that, oh, the heart's weak. That's easy to explain. It's really the heart weak, it's not pumping strong enough. We're going to do this and this and this to try and make the heart beat better. And a lot of times the medicine does make the heart beat better, the ejection fraction improves. So that's the last category. That actually seems preserve the ejection fraction on where it says B, under 2B. But it could actually, rather than be preserved, it might have just been improved. So these are the miraculous people that you put in a biventricular defibrillator in there and you recreated synchrony and now their ejection fraction improves and they feel better and you feel really good about yourself. So that's what we work in electrophysiology. We were sort of a miracle worker that made people a lot better and we felt really good about that. But we don't really know long term if that sustains or if that really helps. But at least we felt back then we were making a difference. So people that know medicine, nothing would help. Their ejection fraction was so low and they were doing so terrible. We put these devices in them and all of a sudden it looked better. So that would be the improved or preserved ejection fraction. So systolic failure is one that's easy to understand. So that's mostly people that have had either a dilated cardiomyopathy, when we talk about that, a virus or something, or they had a big old heart attack. So two completely different mechanisms, and they have dead muscle and their ejection fraction is reduced. So those people, they've got reduced ejection fraction. And we understand why they have heart failure. It makes sense. And we treat the underlying disease as best we can to try and make them go to the improved category. Because if they don't get into the improved category and they get worse and worse and worse, they either die or they need a transplant, if you cannot make them better.
So, when you're measuring ejection fraction, 40% of what?
Well, we said 100% ejection fraction. That would mean the heart is free flowing dry. Does that happen in the heart? If all the blood ejecting is a vacuum? No. So normal ejection fraction is 55 to 75%. Most of these people are range around 55 to 60%. And 75% would be very hydrodynamic. You see that sometimes. Or it could be artificially created. That number could be created because they have sometimes even microreserves. You have an extra volume that goes back to the left ventricle and it's a pseudo increased ejection fraction. The point I'm trying to make is ejection fraction doesn't mean everything. It's not the definition that they have. You can see how they could have a normal ejection fraction, but they have had heart failure. So heart failure, you have the diagnosis and it's with you forever. There's a whole other set of ways you can categorize heart failure. Some people say it's compensated. A lot of heart disease we don't have a cure for. A big example is arteriosclerotic heart disease. Once you have coronary artery disease, there's no cure for it. It just keeps coming back. It's progressive. So all we do is we treat the risk factors, we try to minimize the damage, improve the heart function as best we can. But can we really stop blocking heart failure? Nope. So we call that kind of heart failure, if someone had a heart attack and they recovered, we call it compensated. But that they don't really use that terminology here. That's just some of the favorite ones people have been using over the years. Right heart failure, left heart failure, right heart failure, right heart failure, compensated heart failure, compensated heart failure, and classes of 1, 2, 3, 4 heart failure. So and then we have this favored ejection fraction definition here, a classification of heart failure. So there's lots of ways we can talk about this. accuse you. I'm just trying to see the big picture. That none of you are wrong. Somebody talks about it one way, it doesn't mean they're wrong. So to answer the question, can you be cured of heart failure? Sometimes if it's acute from acute illness, let's say someone had a myocarditis and they exhibited heart failure because they were tachycardic or they had an overactive thyroid gland, and it was a curable disease. So you cured the thyroid disease and the heart failure went away. You cured the tachyarrhythmia, the acute heart failure, they went away. So there goes another description for you. Acute heart failure, chronic heart failure. So you could die from acute heart failure. You had acute pulmonary edema, you were flooding your lungs. So, but then you could recover completely from the thyroid. So most heart failure that I'm talking about is going to deal with is chronic, that's the aging of the population, and the fact we're living long enough to get these diseases. So there's some numbers and stuff for you. So I expect you to understand this differentiation of heart failure and ejection fraction. So the second one is very interesting, diastolic heart failure, and that is mostly from hypertension. So this is what my stepmother died of. She had preserved ejection fraction for a while, and it finally went down. She went on to get dilated cardiomyopathy. The only diagnosis she had was hypertension. It was controlled, but the damage was already done to her heart. So you can have preserved ejection fraction and just simply have hypertension, but yet the person will lose a heart failure. Why? When their heart looking good, ejection fraction is okay. All right. So it says down at the bottom, the older women with hypertension. And there's really interesting all these other things, obesity, diabetes, weight, we'll talk about those because we know also about heart failure. So all kinds of diseases, infections, congenital malformations, and all cause heart failure, with or without the effects of ejection fraction. So then the next page 3, so we're halfway through this document. The functional classes of heart failure are very similar to the functional classes you'll learn from Dr. Javier about coronary artery disease and the detector. They also break in class 1 through 4. So 1 being the least problem and 4 being the worst problem. So class 4 heart failure is usually you would admit them to the hospital that has class 4 heart failure because they're not going to get better on their own at home, and then they have to be at rest. So they don't even have to do any work to be short of breath. They're short of breath, they're sitting there. They're short of breath talking to you. That's called conversational dyspnea. And I think writing, speaking of conversational dyspnea. I diagnosed with a little bone, my stepmother couldn't finish. She talked like this. She couldn't finish the whole sentence because it was hard and she had to breathe so much that that's how she talked. That's conversational dyspnea. So certainly they try. I do a little stress test. I walk them back to the exam room and they can't keep up with me and they can't walk and they're stressing. They're having symptoms. Functional class 2 and 3 is it's like everything else, the graded numbers and things like that. Let's get into the 2 and the 3. It's just 3 courses too. So a lot of my teachers are class 2. 1, they don't have any symptoms. And they're okay with 2. They're just slightly limited, and 3 is more unusual. So that's a little harder. And I had to grade this a lot. So there's a lot of research studies. They want to know what functional class they are because they start to want to imagine a huge research department. They start out there 500 employees just in cardiology department. So with all the research going on, they depended on me and the notes that I wrote to determine what class they were in. They would either enroll them or not enroll them. Because if they weren't, a lot of people decided that they were class 3. So people depend on the notes that you write to be accurate. And here's the statistics I told you. 1 in 5 Americans will be 65 years old by 2050. So this is, that would be 35 years from now. So you'll be like me, you'll be working for me by then. So that's a lot. That means 20% of your practice, they're all going to have heart failure. Okay. So, and African Americans have the highest risk of heart failure. And within 5 years diagnosis. A lot of cancers, the cancers are not treated in 50%. A lot of cancers are better than that. The prognosis at 5 years is better than 50% survival. So heart attack, heart failure is worse than cancer. It's not treated. Okay. So what do we do to prevent heart failure? Well, it's better to prevent it than to treat it, which if you watch the Little Makers, that's really the opposite thing that happens. Let the disease happen and then we're treating it rather than if we prevented it by extremely vigilant risk factor modification, maybe some of us would not play our genetic predisposition to atherosclerosis if we lived differently. So to me, rather than have my chest factors and my bypasses, if I knew that I had to eat a certain way, I had to be a certain way, I had to do a certain amount of physical activity, I had to have a certain amount of checkup, I would prefer that to having my chest open up and having a problem that just can be fixed over and over again. But that's not the way it's going. So hypertension is one of your main diagnoses you're going to take care of pH. So you can make a difference and you can way decrease the incidence of heart failure by treating that. So again, the systolic blood pressure is a major risk factor because diastolic hypertension will give you, remember we talked about normal ejection fraction heart failure, because if you have hypertension, you just sick. People think they have high blood pressure, full plate blood. For the most part, people don't know they have hypertension. So they're not going to have symptoms of shortness of breath, they're not going to have chest pain, they're not going to have fatigue, just because they have high blood pressure, but they'll have diastolic function and heart failure. I talked about that previous start. If they have systolic hypertension, which the cancer like to use, that's the damaging hypertension. If you have high blood pressure that's sustained, because when you go to do something, you momentarily have systolic hypertension, that's normal. But then the blood pressure comes down. Should be hypertension, but elevated blood pressure. Or you cause stress. So that's what everybody knows how to treat. They know what to do. Like, what do you do about diastolic function? You get that number. You don't know, whenever you have with pulse check, you don't normally have the numbers really close together. So you're going to have to solve pulse check with diastolic. The diastolic will come down and you see the solve. That's what it is. Well, not that it's acceptable, but you don't have a choice. It's going to stay high no matter what you do. If you have like 6 different medicines and you can't get it any lower, so you're trying to keep it below the emergency level, but unfortunately, when you get even better medicine, sometimes you cannot cure that. You look for secondary causes. And if you can't find a secondary cause, and you give them all the medicine you can, because you still can't get it that low, and at that point, that's like any disease that you can't cure. But hypertension can be controllable for the most part, especially if you catch it before there's a lot of diastolic dysfunction. So that becomes permanent. And then that will go into the heart failure later on. I'm fine all my life, and now I have heart failure, and you're telling me there's something wrong with my heart, then why do I have heart failure? And you have diastolic dysfunction, and your heart doesn't work properly, and you have abnormal cardiac arrest. Yeah. Yeah, probably okay. Yeah, quit smoking, and the longer is worse, but I can't tell you exactly. Because people are different at how much a disease bothers them. You know, it's like you hear about the person that smokes all their life and never got cancer and they're really old and they smoke cigarettes. Cigarettes can't be so bad, look at him. Or same thing with hypertension. Some people, if I said others who got Alzheimer's and heart failure for 60. And other people don't get Alzheimer's, the heart failure until they're in their 80s. So it's just a genetic predisposition of how the factors that make the heart destroy the heart tissue, how sensitive you are to those things. So there's like a certain percentage of this age, this is going to happen. But sooner treating the better than treating people. We're finding hypertension in kids because of the blood epidemic. Why are kids getting hypertension? Obesity. They're getting diabetic and hypertension. Kids. So that doesn't mean they're gonna have heart failure when they're 15 years old because it takes a long time for the damage to occur to the heart. That's what will happen. Okay, so obesity is the worst, and here's some things I was taught. It was very interesting. Lipotoxicity. I didn't know that the fat was actually toxic to it. But we know that it infiltrates organs, including the heart and the liver. So you get fatty heart like that. It actually damages the myocytes. So when you see open some little tests, you see some of those parts and there's fat all the way around it. So usually there's a little tiny bit of fat at the apex of the heart. That's pretty normal to see, but some there's a whole lot. So it actually causes toxins. The increasing circulating volume, first, the bigger you are, the more volume you have to have to your circulatory system. And if you have too much volume, too much fluid retention, you're going to have abnormal intracardiac system as well. So again, it's too much work. So obesity is almost synonymous with hypertension, and hypertension we just talked about diastolic dysfunction. So even though they may not have ever had a heart attack, they don't have coronary disease, they got heart failure, diabetes. This was a cancer that I wanted to talk about. The drug rositrazone. I don't remember it. The Axel? Rositrazone. Tell me if you know about the trading for that one. If you don't get trading for on the piano. But thiazolidine, yes. I can't say it very well. So you want to memorize that category of medicine. That if you have diabetes, that's associated with fluid retention. And fluid retention can, you want to avoid it if people are class 2 or 4, heart failure, 4. So if you're diagnosed with heart failure, unless they were just very mild, and you want to try that medicine, you could. But as they get worse, you want to alleviate those medicines that are going to aggravate the heart failure. Remember, class 1, CMS symptoms, so they might be safe with that. So that's something to just memorize. That particular diabetes medicine, that's safe. Avandia, thank you. There's no one like that down, but you won't get that on the test of Avandia. You'll get either the category of medicine or an example, for example, what is rhythm. Okay, and you might look up some other ones for that name, or they had a same ending on it to remember. But you never seen that. Thyroid disease causing heart failure. You can actually wear your heart out. So if your heart beats too fast, you can go to heart failure. Think about how do you feel if your heart's pounding? What happens if you run as fast as you can? You get out of breath. You get out of breath. And then when you stop running, it goes away because your heart's normal and you recover and it slows down. If you have a tachyarrhythmia or chronic rapid heartbeat, such as atrial fibrillation, rapid heartbeat, rapid response, you actually wear your heart out and you actually get permanently short of breath and fatigued all the time, and eventually that can start to destroy myocytes. So tachyarrhythmia is not a good thing to always have fast heart because that. And so hyperthyroidism is one of the things that can cause atrial fibrillation. So it's one of the things we always check when people have new onset atrial fibrillation or new onset heart failure. So we check the thyroid function and make sure that's not what causes it. Even something like anemia can cause heart failure. If you don't have enough cells and you're not carrying enough oxygen, what is your heart rate going to do to try and get enough oxygen circulating to your body? It's going to go faster to try and reduce the need for your body. So that you can get heart failure just from anemia. Okay, and then in section E159, causes of dilated cardiomyopathy. Yes. Oh, CCM is dilated cardiomyopathy. It's on the right below that, sorry. It's loaded out. And remember I talked, go ahead. Access is a brand name for another. Yeah, I just remember that. Okay. But again, you won't get those trade names, but people talk about it. So I think you're more likely to get the science or religion, than to get that trade name so that you have a trade name.
So the NYHA functional classification is not the same as the classification of the executive practice. So 1, 2, 3.
No. That's a functional class. Actually, it's functional class. That classification is a functional class. That's just a classification of heart failure. This is 1, 2, and A and B. It's just a classification by ejection fraction. They're making reduced and preserved ejection fraction, trying to explain how you can have a normal ejection fraction that have heart failure, i.e. diastolic and how it could be not really preserved, but rather improved by the drugs or biorehabilitation. Okay, is dilated cardiomyopathy the only thing that causes heart failure? No, tons of things. First and tons of things cause heart failure. Infections, in general, not really. Even if it's fast heart rate. Yeah, that's another one. The restrictive cardiomyopathy is not the same side as the cardiomyopathy. It's certainly a heart failure from restrictive cardiomyopathy. Because remember the first general description of it, the heart failure? The heart can't meet the needs of the body. It can't generate enough blood flow to oxygenate the body. That's the ultimate goal of your heart, to get oxygen to every cell of your body, right? So there's a circulatory system. If you can't get there, you're going to start getting symptoms, whether it be in the lungs, and then the pressure itself goes in to the cells. But dilated cardiomyopathy is one of the more common ways of getting heart disease. And you could get dilated cardiomyopathy can even be, we talked about this, a cause from ischemic cardiomyopathy. Ischemic cardiomyopathy means you actually have a blockage in the artery, and that's the cause of not delivering oxygen to heart muscle tissues. That results in dead tissue, and then the dead tissue results in eventually the heart changing its shape and becoming dilated. But it doesn't start out, it starts out as ischemic heart disease. So alcoholism is one. So not only be a big drinker, but have a genetic susceptibility, because there's plenty of alcoholics who do not get cardiomyopathy. But enough to do that you tell the people that come in with heart failure to stop drinking, just in case that was the problem. When they buy in particular, both the RV and the LV side of the alcoholic cardiomyopathy, it often affects both. Or if you have a heart attack, the majority of the time the heart attack is on this side of the heart. The left ventricle. And you can have right ventricular infarction. We study that in KC, but for the most part, yeah. Cocaine cardiomyopathy is an example of, it can be from rapid heart rate, or if they're chronically using cocaine, you may get tachycardia, you might get that. And some things that the drug itself actually is a toxin to the heart muscle. It doesn't always happen. Some of these drug users that don't get a cardiomyopathy, but other things like HIV and stuff can do that. That would go under myocarditis. We don't understand too much the postpartum very part of it. It seems to be factors from the mother against the fetus itself attacking that, and then from an antibody. It's like an autoimmune process that a mother may attack her own part postpartum, that kind of thing. Phosphate ephedra is Egyptian metabolite. They had a kiosk at the mall where they sold metabolite for weight loss. You go there and you buy yourself a new pack. You just we had people come to the clinic to get defibrillators, and that's all they did was they took that stuff for weight loss. And it's a direct process to your heart. I mean, it's like adrenaline. And adrenaline destroys heart muscle. It's only good for a moment. You only need adrenaline if we're getting ready to fight or studying for a test. And after that, it better go down, and that's going to be good for you. Amphetamines, obviously, that's the same thing, and steroids. Cancer drug, this is our popular cancer question. It's often quote adiamycin, because that's the most well-known and oldest one. Treatment for breast cancer that causes us to get referrals for heart failure and potential heart transplant or breast cancer survivors. So there's some other names of cancer therapies, but you would be able to sort that out and get that kind of question. They're not going to kind of trick you as to which particular chemotherapy. You would get a question on the cancer that would give you either a story that someone had breast cancer and which is a kid fell off and cardiomyopathy, might be and heart failure, might be cancer, or they're going to say something like adiamycin, or maybe with one of these meds with the other. The fact would not be a competing one. I don't think they're going to ask on that level. And the one that I've seen frequently is adiamycin, although there's other ones that are backed up. The 5FQ is adiamycin Adriamycin. And so you can, and we talked about putting out about amyloid and retinoid, so you can do damage to our muscles by deposition of protein like that, and that can do it. And then cerebral cardiomyopathy is, if you don't treat it, and it becomes chronic heart disease, because they have a heart attack before the coronary artery, and they could become a dilated cardiovascular myopathy, like when you recognize it, they end up having a heart attack, and then you know what to do. Okay. Now let's go to Dallas. How are we doing? Are we exhausted? Are we?
That's the wrong question.
Micro, or we? Anything like what's happened here? Because I learned about the paper. I'll let her talk on. So, I'll give you a few pointers here. Risk factors. So when you do make a physical, you want to. The reason you ask about regeneration is because, and let me tell you a story about Dr. Sheldon's son. You might have a family history of sudden death, and there may be some reason why there's so much heart failure in the family. So you want to get history about hypertension and heart attacks, and there's coronary artery disease in the family, so that's to that. The weight absolutely critical, whether or not they are doing detention and we're asking about orthopedy every visit. We're trying to get some of our functional tests. Orthopedy, according to that, just related to positioning to sit up to breathe. And then as far as lab tests, we talked about DNC the other day, so let's move on to that. We could check for forming C1 or forming I, depending on what your institution uses to see if they're having a heart attack. And then non-invasive studies, everybody should have echocardiogram to suspect heart failure. Radionuclide studies is where they inject material was picked up by the heart, and you do 2 scans on it with the therapy for it after exercise, radionuclide studies, and there's other scans that you where you inject tracers to see how much viable myocardium there is. It's like cognitive studies that sort of thing can see if you can get much benefit from a bypass surgery, there's perfusion of the body, you can get PET scans, MRIs are using the heart now. That's what they, yeah.
You not do a treadmill test on the heart failure, you just go right to
I know at this point I'm not testing it in a lot of false negatives. It's not necessarily that helpful. Greater insight is much more specific. So we're looking for areas of ischemia, which is lack of blood flow. In your patients, you don't have to do a stress test. If you're class 3 or 4 by 10, you're probably not going to get very far. You do, they call it a chemical stress test. You just think that speed up the heart rate and dilate the coronary arteries rather than have to physically do that. They're going to get it. So invasive studies is the heart cath. There's no newborn. These are thermal statements. Right heart catheterization is when you want more information than you get either the echocardiogram or there's some candidates who get specific numbers on the right heart catheterization. And biopsy is not just an expression, and I mentioned that before because it's too long to do. So now we're going to go into the treatment. How are we doing? Maybe we'll switch gears and we'll finish these little physical signs before you treatment that everything is ordered. Okay. I really enjoyed making this paper for you about leg swelling because patients think that their legs are swollen, they have heart failure, and they certainly don't. So how do you bring edema? You take your thumb and you warm the patient really slowly. Usually I like sitting in a chair with them, and I don't put them on the exam table too much, but you take your thumb and you press against the tibia, like that, and if you say, I say, this might hurt, because I need to do it, and it might hurt, but if they're warm, and you do it slowly, then there's other times you just go, they grab their leg and you press on their tibia, ow, and then you lost some trust with them. Because you hurt them, and you didn't warn them. So you very gently put your hand out there and you press. And you press firmly, and then you see if there's a dent left. So maybe ever so slightly you have a of that, but it's really not too bad. I didn't call plus one. I just like physiologic. Then I look around the malleoli, so sometimes they puff up and there's no, it's not even any malleolus. So you just, you feel in there. You don't say their feet are puffy or they got marks where their shoe is cutting off their circulation, that kind of thing. So again, that's, I just do it somewhere along here. And then, and usually the edema is below the knee, but sometimes it goes all the way up the leg and even have it here. And that, and another place they might have it, if you look on their back and you look, you check for sacral edema. You go way down here by the sacrum, and you press in there and you see that leads down to their back. And then there's other places they got edema. But it's important you grade that 1 through 4, and that'll be on your drop-down menu on your chart. Or I call it reflux edema. Or sometimes they're losing fluid right down on their legs, they're dripping down there in their carpet in your office, and you have to put checks on the cord. It can be that bad. That's 4+. It's kidney edema. It's edema, sometimes it's not kidney. Sometimes they have lymph edema. That's a different problem. You see that frequently when women have had breast cancer, they have hyperactive the lymph channels were cut, and they put like a lymph node. And lymph edema is this firm edema that doesn't hit. So the lymph system runs alongside your venous system and it's its own system. Lymph nodes and the but on the leg, pitting edema is clear fluid that leaves out of the veins that are under higher pressure than sitting in the tissue. And there's different ways to get rid of it. So one is very mild. A lot of us have one. I get 1+ edema from my meds that I take. This is the oxide potentiator for the favorite diet, the beta blocker that I take. So I frequently have that. And it's not worrying. There's a lot of time on the heart rate. And then 2 and 3 is the dilemma of everything with your brain. From 1 to 4, 2 is 3 is worse than 2, so we get some experience. And then 4, I often call it some people call it yawning edema, and it can be way past their knees, and the vet stays there for a long time. You press your thumb in there, and it just sits there. You can see it. So there's lots of pictures on the internet of what edema looks like. So you treat it. Well, first you're going to diagnose it. So if it's a newer worsening symptom, you might want to consider an ultrasound to see the DVT because if they have edema, but you don't think there's no reason you don't think they have heart failure, if they were traveling or they injured their leg or they're just unilateral, it's very possible DVT, which is the most common cause of death in hospital. Very number or DVT in travel. So if it's a positive ultrasound, we'll talk more about it when the anticoagulation less because the treatment is anticoagulation for 2 months. Yeah. Well, you can lose hair from the hair atrophy because if you decrease the circulation to the legs. A couple causes. One is men who wear socks. So up north you see this. So people don't wear socks. But up north their socks wear away their hair. So sometimes like right at the line there's no hair below. Another is just getting older, people get less hairy when they get older, so they might not have as much. Men, they might lose their chest hair and their leg hair, they don't have a lot of hair anymore, and that's from hormone changes. And then sometimes if you have a lot of edema, then your skin can become atrophic. You can have stasis dermatitis, where the skin is it looks dark or rashy, and it's cellulitis, but it's from stasis. And then you can even get stasis pigmentation, where it looks round, and that's hemocysteine deposit, which is a breakdown of hemoglobin. So the blood is flowing so slowly, the pigment is coming out of the cells with the fluid, and it's depositing in the interstitium. So it's there, and their legs are brown and dark, and you see little patches of that. That's stasis pigmentation, stasis dermatitis, stasis ulcers, and I don't know what to call it, stasis hair loss, but I made it up. So you can lose hair or have all those kind of changes with edema, chronic edema. Not necessarily, but it could just be hormonal stuff. Okay, so if you thought it was not heart failure, but maybe it was a DVT, then you pull that route and you get a full ultrasound or a reflex scan of the lower extremity. So you could do one leg, but I usually do both because I like to have the normal one to compare to the other one, and it's not expensive. So we do that right in our office, cardiology, that's what all these clinics, they do that on Fridays. Different days, they do different body parts. So if it's negative for DVT and you still don't think it's heart failure, but you want to make sure, you want to think, okay, it could be phlebitis. So you'll see that often in the room. Anyone ever gets phlebitis in the arm? Some IV, so 1 or 3 days to get red, you can get phlebitis. You can get a phlebitis in the leg, too. Just because they have varicose veins and if they're that irritated or not because the needle was in there. And abscess infection and cellulitis. I see cellulitis particularly with obese people because of the poor circulation. It's very common. A basis cyst, there's some people with basis cysts like that. And I feel those a lot because I'm very good at feeling top of the pulses. I feel this really how to feel top of the pulses all with 8 fingers and pushing their really hard with their leg relaxed and the whole weight of their leg falling on your fingers. And a lot of times you feel basis cysts or hurts from that, and that definitely causes falling in the leg. And compartment syndrome, much more serious kind of thing. That's when there's an injury to be blunt or sudden trauma. And then the fluid cannot return because the swelling has cut off the circulation. If you cut off that circulation, lymphangitis, orthopedic surgeon, it doesn't have to be recent. Let's take out that word recent, even most. Many people that have arthritis or had surgery have chronic swelling in their legs. Trauma, of course, muscle tear, that's all self-explanatory, strains and sprains and things like that. Snake bite, yeah, that's such an incredible one as well. You didn't know that one. And burns. And pregnancy. I had to get those pantyhose, $200 for a pair of hose that I wore one time and I couldn't get them on. But it's a giant belly that obstructs the indicator return, so you get swelling both legs. I didn't have heart failure, but I had ankles. Anybody ever see a pregnant lady with their ankles fall over the malleolus? Like the skin and the tissue goes over top of it. So it's a giant fat roll, but it's all fluid. So that pregnancy can definitely do it. So you're going to see tons of people that have had knee replacements, especially stay here in Florida, and hip replacements, and they have always got them falling in their legs. Or they get it at the end of the day. It's often cyclical. Heart failure is non-cyclical. Pretty much there. So drugs, steroids, and probably heard steroids causing swelling, right? They cause fluid retention. Calcium channel blockers, I noticed it. What do calcium channel blockers cause vasodilation to hypertension? To increase the space, make the pressure drop. Right? The volume is in the same space, it's now dilated. The venous system is bad. So that's what it causes. So then some fluid also goes into the tissues and the vasodilation, which makes it more permeable, and you get that from that. Hypoalbuminemia, that's a pressure gradient between the cells that are inside the vessel and the cells outside the vessel, and the fluid moves to equalize that. So I saw that in a lot of hospitalized patients have swelling, right heart failure, increased stress on that side, body syndrome, kidneys are losing protein, sponges, it shouldn't happen because you're changing and where the protein is, to equalize the pressure. Venous insufficiency is really common for varicose vein paralysis that happens because you don't have your muscles squeezing, that's the mechanism of returning the fluid back up to your heart. It's parts of the valve become incompetent. And then the pressure builds up in your legs and it gets swelling. But when you walk, your muscles squeeze the fluid back up towards your heart because you know the pressure rise by the time you get your toes pressure to 0, it's coming back up and you need some help. So that's why swelling gets better when you lay down because you don't have the gravity and it can return and the diaries during the night. You have to go a lot, you really get irritated. And you're also eliminating the obstruction. So when you're laying down straight, you don't have these turns. My sore foot has this 90-degree turn there, 90-degree turn at my knee, and 90-degree in my hip to get it up there. So sitting is the worst thing for getting rid of that unit. So even having your legs get rid of one of those tricks by putting your leg out on a footstool, so that helps. And not having to use that. Also pressure stockings, you'll learn to write prescriptions for particular grades of stockings. They're taking this to a knee-high one, and 40% of obviously they go into the treatment, but he's really bad. Okay, so let's talk about jugular vein. Jugular vein is really a big misconception. Pretty much you're all looking at the external jugular vein, and you look at the neck, and you're not seeing the internal jugular. The internal jugular comes off the anomalous vein and the brachial cavity, all the big veins that come off the vena cava, here vena cava on the right side. The left phenomenon is longer than the right. It's got to go across that to the cava on the right side. So anyways, it branches into the internal and external jugular vein. The best one to measure the jugular vein extension is the internal jugular, because it's the most direct line to the right side. But external jugular is better than nothing, but it's not quite as accurate. It takes a longer course to look at a diagonal across the outside of the sternal side of the actual muscle. Internal jugular, you only see at 2 points. At the head of the SCM where it's the clavicle, there's a little triangle, and sometimes you can see the internal jugular there, and then it disappears where it goes under the SCM, and it shows up again at the very top of the neck. So the other way that you can help see it sometimes if you put your finger at the right the clavicle there, and you hold it down, then you prevent the blood from returning from the head, and sometimes it will go out like that. And the second way you can see it is you can press on there really, really hard. Your hand underneath there, just close like you're doing it. You put your whole hand on there, and you press it really hard, and you want your face. I'm going to press this pretty hard, and you might be a little bit uncomfortable. And sometimes they'll light up, and you have them starting like that. So you're just pressing on the liver, and I did that with a few years back. You get some opportunities in the hospital. So either that, or just putting it on the top there, looking to see it. You can see it when it's tearing down, and all that stuff like that. Might just pop out. So you try and find the internal jugular, and then you see that wave. And there's a bunch of waves, but the only ones you really can see is a double one. Kind of goes like that. We really can't discern the descent yet, but we can see the ascent of the circulation. So that is the A wave and the B wave. That's what it means to external. So you can see there's A, C, and D, and 2 negative waves, or a descent of it, X and Y. But I can't differentiate it. I'm looking if I can see a double. First, to try to see a single pole. So you'll see this kind of thing. So the first is atrial contraction. So that makes sense. So when the atrial contracts, you're going to see blood. You're going to see a pressure wave against X when they contract. And the second is venous filling of the right atrium against a closed tricuspid valve, the V wave. So when it's filling, and then it contracts. So the atrium has a filling the diastole just like the ventricle. This is one place where you can see it. Whereas the carotid, you're going to feel filling the diastole based on the pulsation, and then you don't feel a pulsation. Pulsation is the closure of the valve, and typically the diastole is you feel nothing, you see nothing.
Does someone in AFib not have A wave?
Excellent point. With someone in AFib not having A wave, it's really difficult to assess the A wave. You also don't get an F4 filling sound of the atrial filling sound in that atrial fibrillation. The atrium are quivering. They're still contracting, but they're contracting so rapidly that you won't see the same pulsation. Correct, that's a tougher way to diagnose it. Either way, you just have to look on the test. But the actual confirm that. Okay. So this one is about